Thank you, thank you, thank you. Good morning, everybody. The meeting of the Family Care and Aging Committee is called to order. I don't want to waste any time this morning because we have a lot of important discussions to have. We all know how the coronavirus has impacted and is affecting our long-term care facilities in Minnesota. And we all know somebody who is either in one now or has been or will be, and those lives matter too. They are our most vulnerable citizens, and we need to make sure that we're doing everything we can to protect them. The past 2 months have been exceptionally challenging for everyone, but I can't imagine anyone more than Commissioner Jan Malcom. I want to start this meeting this morning by thanking the Commissioner for her hard work and dedication on behalf of the people of Minnesota. I doubt very much that Commissioner Malcolm has slept much in the last 2 months, but we appreciate it, and we appreciate you and Chris Erzman being here today. So thank you. Back at the beginning of April, we saw the writing on the wall. We got reports that the vast majority of deaths were happening in our long-term care facility, our congregate care facilities, and each day that trend is continuing. And we are quite literally standing at the verge of a major crisis here in Minnesota if we do not act immediately. I also want to say this. The caregivers across Minnesota are doing the best they can in extremely difficult circumstances. Employees of long-term care facilities already had a trying job before COVID-19 hit us, and adding a pandemic to the plate is not easy. We need to keep the work they're doing going, and as we're going forward, make sure that we keep them in our discussion and our plans. These workers are scared for their safety, the safety of themselves, the safety of their families, safety of the residents that they protect, and they're scared they're going to be abandoned if an outbreak occurs at their facility. They need to know that we have their backs, and we as a committee need to know that the state is doing everything they can to join them. So Commissioner Malcolm, I ask you to provide the committee with a brief update as to the data. Everybody already has their PowerPoint presentation. They have it printed up. But the data that the department has on the situation at the Long-Term Care Committee. And then I'd like you to share the department's action plan that I hope is already underway to help prevent this from happening and help protect our most vulnerable. So Commissioner Malcolm, I'll let you take it from there. It looks like we have a quorum. A quorum is present. So Commissioner Malcolm, we can take it away. And I think Brittany is sharing your screen. So go ahead. Thank you again, Commissioner.
Great. Thank you so much, Madam Chair, and good morning, members. It's nice to see you, even though only virtually. I really appreciate this time. And Madam Chair, you teed it up just perfectly. I think I couldn't agree with you more that this deserves our close attention, has had our close attention since the beginning of the outbreak of the pandemic here in Minnesota, but we are learning a lot and adjusting as we go. I appreciate Chris Erzman joining me. I think there may also be a couple of additional MDH staff available as resources as we go. You just said it correctly. I think we know that our long-term care provider community was under a great deal of pressure and stress even before the pandemic hit, with the rapid growth in the population, the growth in care facilities, the workforce challenges. All of that has been true before, and it's like this pandemic is shining an even brighter spotlight on the systemic issues that this committee has been working on and frankly struggling with us to address in an affordable and sustainable way for quite a long time. Is Brittany going to advance the slides, or do I have control of that?
Commissioner, Madam Chair and Commissioner, I can advance the slides. Otherwise, it might be easier if I just do it. Otherwise, I can't allow you to share screen, but I think I can plan to do it.
Thank you. If you would, I'd just advance to the next one. I'll just say next one as we go. Thanks, Brittany. Okay, next, ready to go? Good. So, and as you pointed out, Madam Chair, just sheerly demographically and by virtue of the conditions in any congregate facilities where there's close contact with people, we knew from the beginning that long-term care facilities and the people in them were going to be at an elevated risk of COVID-19, both in terms of spread, but also the severity of the impact of the disease on those of advanced age and with underlying medical conditions. So this really is sort of almost the perfect storm in terms of an elevated risk profile. Next one, please. Thanks. So literally since the beginning, we have been trying to provide a lot of guidance, a lot of information, a lot of coaching and support to long-term care facilities and provider organizations across the care continuum, but really focusing on long-term care because we do know how important that is. We've been having weekly calls with that the associations have helped us, care providers and leading age have helped us set up since early March, really. And every week we're on the phone, trying to clarify the guidance that both CDC and MDH have pushed out to the field. But we know oftentimes that guidance needs explanation and lots of questions about what does this mean and that mean. So that's been really the focus of those weekly calls. And they're very well attended. The last call had about 1,500 participants on it. Next slide. Next one, thank you. So what happens when we get even a single case in a long-term care setting? And quite honestly, this has been kind of controversial. As you know, we began publicly posting on our website a list of all the facilities that have cases, and we've set that at all the facilities that have even one case, and that there's been a bit of unintended consequences to that, quite honestly. So we're considering whether we maybe should have a higher threshold for what we consider to be reportable, but we understand that there's an awful lot of public interest in this, and we completely embrace the need for a high level of accountability in this environment. But the fact that there is a single case in a facility triggers a response from us that starts with getting on the phone with the facility administrators, clinical staff, and an epi team from MDH to just make it clear that this is on our radar screen and it needs to be on theirs, and that we're going to be in literally daily contact with them. And we focus immediately on trying to coach them on further work around infection control. We know how very vital that is. We start talking right away about how to focus on healthcare workers, how to think about the exposure risk and the management of that within the workforce within the facilities. And of course, we do the epi investigations of interviewing the person with a confirmed case, understanding about their movement patterns, who they've been in contact with, and doing then the next circle of interviews and interventions with those close contacts to help identify any exposed residents and healthcare staffs. And I'll get through this slide deck and we can open up for your questions, but Chris could explain that part of the process much more in depth if you'd like. Next slide. Thanks. So we've been, as I mentioned, pushing out an increasing amount of guidance, increasing specificity of how to manage both the resident issues, the personnel issues, how to further assess the risk of exposure. And some of the measures that we have been working with the facilities on is how to isolate or cohort, meaning co-locate all ill residents, and quarantining all those who've been exposed to prevent the further spread around the facility. A lot of focus has been on the types and the proper use of personal protective equipment that is needed in various patient care or resident care situations. And this is certainly something that has changed over the last weeks and months. There was absolutely a dearth of appropriate personal protective equipment in long-term care. We've been working hard at the state level to try to build up that supply and get it out to them. I won't say we're all the way there, but we've made some pretty good progress on getting more personal protective equipment into these facilities. We also advise the facilities on extra disinfection and cleaning protocols. We offer them regular virtual inspections of their facilities around infection control practices, and we provide monitoring tools for symptoms for use in the facilities for both care of residents and workers. Next, please. And each facility with even one case gets an assigned health department case manager. And these are nurses typically from the health regulation division. And one thing I just want to mention to the committee, and Madam Chair, I think you're well aware of this, is about 80% of the regulatory staff have been redirected into direct support for outbreak management. So the people who have been working historically on inspections and regulatory activities, we certainly continue to do that where and as needed, but most of the staff resources have gone into this more consultative, proactive, direct support for management of COVID. And we can come back to that in the discussion. So the case manager literally checks in daily with each of the facilities that case manager is assigned to help make sure that they understand and know how to apply the MDH and CDC guidance given the specific realities of their facility, their population, their staffing patterns, and the like. This case manager is also the point person to help connect that facility to other MDH resources and this is quite key and something we've done more recently, to the State Emergency Operations Center to provide an additional level of access to surge support, if you will, depending upon their needs. We've stood up a long-term care group within the State Emergency Operations Center, which is highly appropriate and a big deal because, as you probably know, the general focus of the State Emergency Operations Center is really, acute emergency management, and so it's kind of emergency management oriented, and in the case of this particular emergency, acute care oriented. So standing up a long-term care group inside the SEOC, I think, was a major advance just in recent weeks to allow us to really coordinate more state resources in support of long-term care. Another thing these case managers have been doing actively is assisting facilities to safely transfer patients with COVID-19 inside their facility for that cohorting process that I mentioned, or to transfer residents from facilities which are losing capacity to provide services to a facility better able to care for them. And to ensure that facilities, again, have the tools and resources to safely care for residents. The PPE supply, we've kind of pre-positioned PPE around the state in our regional health department offices to try to get it closer to the long-term care facilities, to get it to be able to get it to them more quickly when they need. Again, we can talk more about that process as we go. Next. But just put this in context, in absolutely no way am I at all wanting to minimize the importance or the severity of this, but it's just important to put it in context that it is the case, as you see in the second bullet there, that we have 231 long-term care facilities with at least one case. But back up to the first slide there, and I'm not sure how to make the pictures go away so I can see the full data on the slide. Sorry about that. 62 of 375 nursing homes have cases. So it's not a trivial number, but the point here is the majority of our nursing homes and the great majority of our assisted living facilities do not have cases. And I think there's kind of a growing public narrative that this is just rampant all across long-term care in our state, and we'd like to do a better job of painting a more accurate picture. 73 of, I believe that number is 1,500. I can't see it. of assisted living type facilities having cases. So again, the point being, this problem is relatively focused in a certain number of facilities. 96 facilities have 1 case, 37 have 2, 93 have more than 2, but there's probably 15 or so that really have, the most significant outbreak challenges right now. A maximum of 157 cases in one facility. It's a very large facility, but this is a significant share of the population. This is like 35 or 40% of the residents having tested positive in the facility with the most cases. But again, over half of these 231 involved facilities have 2 or fewer cases, and that's a metric we're really closely tracking, is to make sure those with no or very few cases stay that way. Absolutely, we have to do everything we can to help those who've got significant outbreaks already. But equally important, taking all the lessons learned to help keep the facilities that have no or fewer cases in that same status. Next slide, please. So as I mentioned, I think a lot of things have changed in the last 6 weeks. When this crisis began, we didn't really have a clear picture of the role of asymptomatic people in spreading the disease. So our approach to kind of the disease investigation, the contact tracing, and the testing and the intervention has expanded beyond just those with immediate symptoms. That we have been focused on priorities in testing, and we're interested in working on how to expand that testing regimen. And we'll get to that in just a moment, Madam Chair. I know that's a particular interest of yours. So as I mentioned, standing up a long-term care group at the State Emergency Operations Center has helped us to get more robust in our response to current crises, as well as to develop a long-term planning response, because it does indeed appear that this health crisis is going to be with us for quite some time and will be an ongoing issue, as are other infectious diseases, to be sure, inside these populations. We've got lots and lots of infectious disease issues in these facilities all the time, as you well know. So COVID is an addition to the list of things we always worry about with long-term care, and because of its severity in the very old and in those with underlying health conditions, it has kind of jumped to the top of the list of those that we're closely monitoring in long-term care. So it's important to do both emergency response, but a longer-term, beefed up plan for management. So what this team at the State Emergency Operations Center is doing, and Michelle Larson, whom you know, who is our HR director of our Health Regulatory Division, who continues to drive kind of the reinvention of the Health Regulation Division and the implementation of assisted living licensure, is now really the kind of the lead state manager on the crisis response as well. So that has had a very, very significant impact on our capacity, as you know, Madam Chair, to keep working on the assisted living licensure stand-up, which we have now asked for a 1-year delay in, just given the reality of the need to focus on COVID is like the jobs 1, 2, and 3 for all of us at the health department. So we'll come back to that too if you want to know more about staff reallocation or to further discuss the assisted living licensure timeline. But so what this Emergency Operations Center, that the team that Michelle is a part of, is doing is putting together a more robust capability to respond when a facility has a crisis issue like staffing. And we've had several instances where either there are so many staff that are out sick, or in a couple of instances where staff are becoming very, very worried and not willing to work. So how we can step in and help make sure that there is staffing, often with very little warning, and building a crisis team to immediately respond to facilities that we can see are coming up to that point, that may be at the risk of becoming overwhelmed with case growth or or staffing challenges, et cetera. We are also, and I believe this is in place now, starting an information hotline at the State Emergency Operations Center for long-term care facilities to call for help in answering specific questions that they have specific to their situation. So it's a real-time consultation, call the number and be able to report a situation or get some help. And determining who can help and where with some of these fast-moving outbreaks. Is it a job for local public health? Is it a job for the local healthcare system? A job for the local emergency management system? And really, it's all of the above. But that state emergency operation team is helping to kind of triage and coordinate who all needs to be involved in supporting a fast-moving crisis. And then again, just kind of learning to the best of our ability and as fast as we can from these individual case situations, developing more of a playbook for how to do this better. Because unfortunately, we know this is just a reality that this is going to continue to be a big challenge for our providers in our communities and for us as both from a prevention and regulatory standpoint. We are looking into our regulatory data to look at kind of past records, if you will, to spot facilities that, based upon their past regulatory record, might be at higher risk for problems, just given past infection control issues or other things that the regulators have seen during the normal course of their business, to try to, again, proactively determine who might need a little more assistance in making sure that they are implementing CDC and MDH guidance. Next slide, please. So into the testing discussion. Over the past week, as you know, at sort of as a statewide strategy, we've been adding significant testing capacity. We're putting in place a system to better manage and maximize and fully utilize all the testing capacity that exists in our healthcare systems, because a lot of them have capacity that they're not using because they can't get access to the right material, the right reagents, or the right transport media, or the right swabs. So, if you will, to make sure that we get material to the right places at the right time to meet where the testing needs are greatest. And that certainly includes some of these hot spots, so that the local healthcare facility that's nearest to a place can help with that testing, with collection of the samples on the front end, and then process. And we've a really nice steady uptick in the number of tests statewide that we're able to do each day. And we absolutely share your priority, Madam Chair, of remains a top testing priority for that capacity, and to be able to expand the way we think about testing in long-term care as that capacity continues to grow. We saw the first cases specifically in long-term care toward like the third week of March, I think. It's kind of amazing when we think about how much has happened in a relatively short period of time. It feels like several years, but it's really been only a couple of months that we've been fully into this. So we started seeing the first long-term care cases. Again, it's what we expected just from the demographics and the reality of this disease. So on April 1st, we put out a health alert message through our health testing of residents and staff and healthcare workers testing priority and access to help support that capacity. And as a result of doing a lot more testing, so we have been testing a lot more in long-term care. Really, the priority populations since the beginning have been people who are already in the hospital. Testing them, if they come in with COVID-like symptoms, they get tested immediately to see if they do or don't have COVID. So those patients that have been hospitalized have been all tested for COVID as well. Any symptomatic people in long-term care have been a top priority for testing since early April. So we've done a lot more testing in those populations. And so no surprise, we have found a lot That's where we expect them to be. That's where we focus the testing, and that's where the confirmed cases are coming from. And that's just true on a day-to-day basis as we report X more cases and X more deaths. Unfortunately, the vast majority of the deaths especially have been in the population. I think so far about a third of the total COVID cases have been among the elderly, and specifically among the elderly residing in long-term care settings, but about 2/3 of the deaths or more, 3/4, I think, even as of the last data that I saw. So we've been looking in this population, been testing heavily, and could test more, we agree. But we know that testing alone isn't the solution. We need to know what to do with the test results when we get them. And certainly we're aware of facilities that have taken a more expansive approach to testing. And we've seen some examples where aggressive testing of residents really did help to more early identify the spread of COVID and help to that facility to successfully contain the spread. But we also know of other situations in which there was also aggressive testing, yet the cases continued to climb. So I'm sure the committee completely understands that it's not just the testing, it's having the capability to respond to what the testing tells us. Next slide, please. Which is this slide, that we absolutely have to get back to how strong are the effective prevention and control measures in these facilities. And another point, I think everyone's interested now in, well, should we just test everyone, just proactively test everybody in a facility? I think our view on that has been, there are some situations in which that makes sense, that a kind of a facility-wide testing scheme might make sense if we know there is a certain amount of disease in that facility. In terms of of testing just proactively, just to test, we've had a couple concerns about that. One has been just the limitations on testing supply, but that's getting better. But we also testing gives you a time data point, if you will. And you're going to need to keep testing, do repeat testing on some schedule in order to keep on to understanding if you really have exposure happening among workers or among residents. And we have a team from the Centers for Disease Control and Prevention visiting us in Minnesota for the last couple of weeks right now. And they came specifically to work with us on some of our settings in Minnesota, because we still are a low prevalent state. We are still early in our outbreak, and CDC was looking for some states to come visit to say where communities and states are still sort of at a low point or a modest growth point in the epidemic. What can we learn to help them stay that way and to try to avoid some of those more rapid exponential growth curves that we are trying to smooth out and slow down with our community mitigation strategies. So CDC's here right now working with us on this. And we're just doing a study right now. It's called a point prevalence survey, where we're collecting samples in a variety of different settings, and then to get kind of a baseline, and then to do repeat testing a couple of additional times to try to establish more clarity around in order to get a good sense of what's really happening. That's kind of in the weeds, but that's really, really important as we talk about adopting perhaps a more robust proactive testing regimen. We're going to have to figure out what that means and how often we're going to need to do it in order for it to give us valuable information. But we will be absolutely happy to share what we learned from this point prevalence study with you, Madam Chair, and members as soon as we have it. Next slide, please.
And Commissioner, if I could here for a second, these last two slides, can you hear me, Brittany? Maybe you can't hear me, Brittany?
No, yes, Madam Chair.
Okay. So if you could do these last two slides quickly, Commissioner, I've got like a bunch of people waiting for questions and I know you have to leave at noon. Okay, thanks.
Sure. So yes, well, we have a lot of information to share with you, but yes, we'll go quickly, and you can certainly review these at your leisure. This is a chart that Chris pulled together, Chris Erzman, just showing what we know to be true, how very much more dangerous this condition is for the elderly and for people with underlying health conditions. You can see there the numbers of cases, the numbers of deaths by age group, and then further sorted by whether those cases and what the case fatality rate is by large age group and by setting. So as we know, the folks who are in long-term care have greater health needs and greater fragility than their same age peers out in the community, and you can certainly see that in the case rates here. So we can go quickly past this one and the next one too, I think. These are a couple of data slides. Yep, this is an epidemiology curve that just shows how things have progressed in long-term care facilities among both staff and residents. As I mentioned, we started really focusing on this as a testing priority at the end of March. And both as a result of doing more testing and the progression of the cases, you can see what's happened. Toward the end, in the more recent days, there is a kind of a lag in the curve. As we know, there's a gap in time between the exposure and the development of symptoms and the validation by test. So those lines toward the end of this week will go up most certainly. Next slide.
I think that's it.
That's it. There we go.
Okay. Thank you so much, Commissioner. Really, really appreciate that update. I am extremely worried about the staff at these facilities. We have heard that in some of the facilities, the staff has just walked out and left the residents there, and then they've had to move them to other places. And I hear there's more coming, and I've heard that they may just be calling 911 and saying, we're out of here. There's 45 residents here that need a place to go, and you might want to just take them. They're going to have to go to the hospital. So I'm wondering, because we already had a staffing issue before COVID-19, and now I've heard from the facilities that they've never had staff report that they have a heart murmur more now than they ever did, so they have to leave. So they're even shorter on staff. But I've got a couple of questions. But what and because if we don't, I mean, it's the whole industry is gone, and then we have no place for me to go, and our loved ones, to help these people out, either at the state to bump up their money. I know that they were increasing wages by $3.
I'm not hearing.
Suggest that they work over in elder care. I know.
Madam Chair, my apologies. I don't know if you can hear me, but I'm apparently having some bandwidth problems here. I'm catching very little of what you're saying. So I don't know if you can hear me, but I'm hoping a couple of my colleagues are chiming in.
Karen appears to be cutting out. Jan, you're not alone.
Yeah. Geez, can you see me now?
Yeah, we can't hear you.
You can't hear me?
I can hear barely, but I think it's your connection, because I can hear everybody else just fine.
Okay, I'm gonna flip right to Senator Abler. Ask your question.
Thank you, Madam Chair. Can you hear me?
Yeah.
What's that? The Verizon commercial. Can you hear me now? So I actually have many questions, and I'm going to still limit myself to like two. And Commissioner, just to preface all this, you heard me say more than once that I think you're a really good choice to be in this position at this time. And so I hope you remember that as I ask my questions. hearing from people who talk to both of us as chairs, Senator Hosley and myself, the comments about how the anticipation and early implementation and even current affairs with the department and standards and PPE and all that have not been stellar. And you even remarked that it's, it's not all the way there yet. And with the PPE and so on, it seems like I don't understand how it couldn't be there all the way. The governor has taken a very heavy hand on Main Street businesses and shut them down and made all kinds of orders. It seems as though if there was a best practice and things they needed to keep all these folks safe, that he could just demand that that gets sent there. And what the effect is that people are beginning to have less confidence in the central administration because of things like that, where they see something they understand and then they don't understand this. So could you please comment about that? Could you hear me?
Issues on my end too, because I'm missing some things. I think I got your main point there, Senator, about the robustness of the PPE, given that we've been putting a lot of effort on it and it remains a challenge. I would invite my colleagues who are also on the line to please feel free to chime in as well. But I think, one of the challenges has been, as I mentioned, for instance, when it comes to the strategic national stockpile, which is something we traditionally really rely on as a means of surge support. Number one, that's been less available just because this is truly a global and nationwide thing, and any supplies there has gone to other communities, not so much us. But that's also restricted to acute care. So we have had to, and we put a big priority to augment what isn't coming from the strategic national stockpile for acute care, but also making sure that we're clear on what the needs are in the long-term care setting and getting that for them as well. And you can see on the governor's dashboard, I think, kind of what's been ordered, and a whole lot of stuff has been ordered. It hasn't all been delivered, and we're painfully aware from other states' experiences that sometimes you have orders and somehow before the order gets shipped, something changes, and it's not. And this is Commissioner Alice Davis's work stream that she's leading. But I know that my team that's down at the State Emergency Operations Center is talking with her literally daily. So Michelle or Marie, anybody else who might be on the line, feel free to jump in here.
Commissioner Malcom, this is Marie and Chair Senator Hosley and Senator Abler. This is Marie Dotseth, Assistant Commissioner at the Minnesota Department of Health. And yes, to Commissioner Malcolm's point, we are working on this daily to get orders and shipments out. Just this week, we pushed a big order out to. Are you able to hear me? Sorry.
Yeah.
We pushed a big order out to long-term care organizations across the state so that they all got a base level of PPE. And then we continue to do that specific to outbreak facilities as well. And we are ramping that up. Every week that we get additional PPE, the supplies for long-term care are being pushed out and ramped up.
Madam Chair.
Senator Abler.
I think we have a bad Zoom connection here, because I think that it's just too bad. It's such an important topic. So I'll just shorten my questions up. I'll just try to put it more straightforwardly. As your department has led the charge on deciding what to do, it seems to me that there's some areas that have been overdone and some areas have been underdone. And it seems in this niche, as I just talked to people, that the anticipation wasn't there that might have been there, and you have the benefit of hindsight now, but even looking forward. And then some areas that really don't need a lot of attention, like some of the closing of other small businesses, has been overdone, and attention was directed away from that. So I'll let you comment about that, and then I'll stand down. Thank you, Madam Chair.
Thanks. Commissioner?
Yep, Madam Chair, Senator Abler, I certainly understand your point there, and I think balance is important. Trying to understand the repercussions of all of these things, and to try to strike that right balance. We are certainly understand your point about feeling that some of the community mitigation measures have been overly stringent. The governor's been very clear that he's looking for ways to open more economic activity in ways that are safe. You have provided a lot of input. I know you will continue to. How do we, in the experience of folks in the communities about that? But I think when we see these rapid rises in cases, in the literal explosion in cases that we've seen in the last week, going from 0 cases to 800 in Nobles County in a week, just kind of shows what can happen. And around keeping our eye on what's happening. But I hear you, and has
Thank you.
changed just about our disease since the beginning of this.
Thank you, Commissioner Malcolm. I have my question now. And then after me, we've got Senator Koren and then Senator Frantz. I am extremely worried about the staff at these long-term care facilities, because we've heard in some of the cases that the staff just vacates and there's nobody there to take care of the residents. In the last case, they had to farm them out, if you may, to different homes. So you had 50 residents that were gone to and moved out to other homes. And I hear there's more of that happening, and there's probably going to be news tonight or tomorrow that's going to be another one. And so I'm wondering, what is the plan at the department to help these caregivers? Is it because when we have no caregivers to take care of our loved ones, we have no facilities, so there's not going to be the whole industry is going to go down if we can't support the staff. They're scared to death right now. They're wearing raincoats to take care of COVID patient or residents. And are we going to, and I think we do need to work together on this to figure out some way to pay them more if they're working with COVID patients, or could we get more healthcare workers that have been furloughed to come back and work in our long-term care facilities? Can we make sure that our staff at the facilities are getting the PPE supplies first? That's the plan I need going forward, because we're right there at the beginning of this crisis, and it's just going to continue to explode, and they're scared to death, these staff, not to mention the residents and their families and everybody else. But what's the plan going forward when it comes to making sure we have staff at these facilities? And then secondly, what is happening with if somebody does have COVID, they go to the hospital, or are they staying in the facility, and are they just passing away there? How is that going? What's the process?
Madam Chair, we hear you loud and clear, and we completely share your concerns about the need for both as good as we can get on emergency support to these staffing crisis situations that pop up, sometimes with little notice. And the team has done an amazing job of getting folks in there and in there quickly. They literally are monitoring day to day. Is anybody on the precipice of having a staffing crisis today, and trying to mount an emergency response, but also trying to have a better long-term plan, because we know you're right that this is an industry under a lot of stress at the best of times, and we're really looking at all available solutions. Your idea of of incentives, of support, of PPE. The team is working on. I gave you kind of the broad outlines of what we're trying to do, but they're working on a more specific plan, which we'll be happy to share with you. It's got perhaps a little more specificity to it that you're looking for. In terms of what happens in terms of transfer to hospital, a lot of that, quite honestly, is driven by the wishes of the patient and the family. some patients are in very advanced disease of other sorts before they get COVID, and they've got end-of-life care wishes in place that are, of course, to be respected, and we want to make sure that everyone has got those clear wishes expressed. So a significant, and then Chris, I know, is on the line. She may or may not have the data right in front of her in terms of the percentage of residents who are going to hospital or are not going to hospital and where they are passing away. A significant number are remaining in the facility either because that's their wish, or perhaps that the disease progresses so quickly. But we can get you that data breakdown if Chris is not on the line or doesn't have it right with her.
We can wait for that data. That's good, because I did hear from a facility that 3 of the residents that died were already on hospice, but that they were designated as a COVID-19 death. And I've also heard that if the staff does up and leave, they may just be calling 911 and saying, you can come and pick up everybody and bring them to the hospital because we don't know what to do with them. Anyway, there's Koren, France, and Senator Koren, France, and Newton, and we only have 12 minutes left. So Senator Koren, go ahead.
Thank you, Madam Chair. And Commissioner Malcom, so we've had, I appreciate the work you're doing, and we've had a variety of conversations, and this kind of goes along on what are we doing from a government workforce preparation perspective. If you remember, our previous conversations have always been about, are we training all of our DHS employees, our Department of Health employees, so they could be the emergency workforce just for this very type of scenario. So I'd like to know, what are those conversations, and hopefully if this doesn't bring transformation to how we deliver our government services and the agencies and who we train and what we do, I'm not sure what will. And so what are the long-term things that need to be put in place that we need to plan for? And then you mentioned about trying to staff up the emergency staff. We've got this same issue. We've had it, group homes, you name it. This same issue come across all of our care providers or facilities. Where are the emergency staff coming from that you talked about to staff these nursing homes that are in crisis today?
Commissioner.
Madam Chair, Senator Koren, I turned my camera off hoping that would preserve a little bandwidth. I don't know if it is, but so thanks. Yes, certainly furloughed healthcare workers. We're having conversations about whether some of them would be available for some of this, as well as state staff who've been either reallocated or and training them, looking for volunteers among health professionals, among students, among state staff, really all of the above. And to your point, I think this we have so many lessons to take from this about preparedness in general, and not to assume necessarily that this is a once in a generation event. We have to be better at planning for the ability to meet challenges like this more as a part of what we train for and what we prepare for. I do agree with you, but there are conversations about how to use redeployed state staff. The National Guard has been a part of this in some instances, but the healthcare workforce itself is certainly kind of first choice in terms of their preparation and their ability to come in quickly.
Madam Chair, quick follow-up. And so
Senator
Commissioner, if you know, 3 years ago we had the same conversation, and we could have been planning, and we didn't have an overabundance of resources for the natural things that occur outside of those things labeled as pandemics. We had horrible flu seasons and all of those that come about, and a little troubled that, I know we're learning a lot of new things, but we spoke about many of these things over the last few years, and it's not just, and you've been wonderful, but we haven't seen any action at the governor's level or any of the other agencies on all of our care facilities. And so again, the invitation's out there again. we have to redefine how we train all of our state resources. They are at home deployed. I can tell what's it, 7,800 DHS employees, another 10,000 county employees. They should be emergency already trained response team that should be able to respond to these things. So with that, Madam Chair, I thank you.
Thank you, Senator Koren. Senator Frentz.
Thank you very much, Madam Chair. And thank you, Madam Chair, for your comments about the staff at these facilities. Commissioner, first of all, thank you on behalf of all of Minnesota. You have been fantastic. You have already saved literally countless Minnesotan lives. The only issue is they don't know who they are because they didn't get sick or they didn't get a phone call. My question has to do with the Department of Health and recognizing that our staff needs at these facilities and PPE. How will you advise the governor to balance the desire to return to some elective surgeries and the PPE demands there with our needs to provide PPE to our frontline workers in long-term care facilities? I know they're both important. I think the committee would just appreciate a quick comment from you about how you will balance those two competing interests. I know there's not enough PPE for everybody, and I know we want to return to elective surgery, but we have these workers and we have to protect them. Thank you, Madam Chair, and thanks, Commissioner.
Thanks, Senator Frentz. Commissioner?
Thank you, Madam Chair. Senator Frentz, thanks for those kind comments. There are so many people working so hard in public health at the local and state level, as well as in our whole healthcare continuum, acute care and long-term care, and they all appreciate your sentiments there. Yes, that is a very difficult but important balance to strike, and I think we've got a draft of proposed changes to the executive order on elective procedures out for comment right now, and we are definitely trying to take the stance that any provider that wants to start up additional procedures needs to be able to do that in the context of, in their own practice environment, conserving PPE that they might need, but as a state, that we need to feel confident that what we've got in the state, sort of the state stockpile that we've been building up, is sufficient to meet those long-term care needs as well, because this is obviously not just about the hospitals and the acute care systems, as important as they are. That is completely right, and we will absolutely keep our eye on long-term care as an epicenter of this as well.
Thank you, Madam Chair. Thank you, Commissioner.
And I must have had this wrong in my calendar. I had it just 11 to 12, but I guess the invite was sent out 11 to 12:30. So if everyone had that blocked out, that would be great. So because we do have some more questions. So I will go to Senator Newton. Got to unmute yourself, Senator Newton.
Thank you, Madam Chair. I have a couple of specific points. One on the long-term care deaths. Is there a possibility that we could add those on the case information bulletin that you put out daily so that we know? Because I hear every time there's a press conference and the governor or you are asked, Commissioner, people want to know how many of the deaths were in long-term care facilities. Secondly, are you including in the number of new cases and deaths people who are in the Minnesota Veterans Homes or the VA facilities in Minneapolis and St. Cloud? And then, Madam Chair, I'll continue and then she can answer all these at once. You mentioned the National Guard, and I saw you had mentioned it a couple of times of using them. There's National Guard and there's National Guard. And we want to make sure that if we have Guard that come in, that they're healthcare trained and that we're not assigning infantry or artillery soldiers to try to do a job that they're not trained for. So and one more thing, in those facilities where we have multiple occupants of a room and one of them comes down with COVID, are we isolating the others and having them in different rooms? So if I can leave you with that list, Madam Commissioner, I appreciate it.
Commissioner?
Yes, Madam Chair, Senator Newton, and Chris Ayersman, if you're still on the line, please check if I get any of this wrong. We do tend to verbally report the deaths attributed or associated with long-term care residents and staff every day. I don't know that we report it on our website. If that's your request, I think we can do that. In terms of counting residents of the veterans facilities, yes, I believe that they are included in the totals. Chris, correct me if I'm wrong. In terms of use of the guard, yes, you're right. There is a fairly small subset of the guard that are healthcare trained, and those are the folks that we that we look to for help in some of these emergency staffing support situations. Other states have made broader use of their fuller guard complement for other purposes, kind of related to emergency support in general, getting supplies where they're needed, potentially playing a role in expanded just surge capacity logistics supports. So, but when we speak of getting staff into the facilities, absolutely the first priority is physicians, nurses, folks with paramedic or other training. And in terms of the when there are positive cases, absolutely the close contacts of those cases are also quarantined, and we try to concentrate or help the facilities concentrate the physical settings in which folks are in. Some of them have like dedicated wings of the facility where they have the folks with exposures. But yes, that's very much a part of the protocol to not only isolate the people who are positive, but the exposures as well, the potential contacts.
Yes, if I can come back in, Madam Chair.
Senator Newton.
I was referring to the website, and I know during your daily briefings that you always have members of the press asking how many of the deaths were attributed to long-term care facilities. So if you could add that to the website on the death category, that would be helpful. And the reason I asked about the veterans homes and the VA is I received a text message from the commissioner of the Department of Veterans Affairs, who indicated that we had at least one death that I know of in a Minnesota veterans home, but it wasn't recorded with the state because they're recorded separately as a federal issue. So I think it's just something we should look into to make sure that if we are having deaths or cases reported in either the veterans homes or in the VA facilities, Minneapolis and St. Paul, that they're included in the state numbers. So thank you very much, Madam Commissioner and Madam Chair. Thank you.
Thank you, Senator Newton. Senator Hoffman.
Hi, thank you, Senator Hosley. This committee is really a really well-acting committee, not acting in the sense of, nobody, but the questions are process and systems questions, and people are asking it without personalizing. So I just want to say hats off to you for running a good committee. I want to add one more to that list that Senator Newton just brought up, and as we're looking at reporting, it's important because we know, just for example, 77% of homeless people within the metro area live with a disability. And I want to know what we're doing within those elements of the COVID cases that are happening. Where is the breakout for people with disabilities in there? Because we know systemically that the systems approach to that, and sometimes people with disabilities are left out on the side of the reporting area. I just want to make sure, since we're looking at those other ones, Madam Chair, if we could add people with disabilities within that breakdown, maybe that goes through the Ombudsman's office as well. So thank you.
Thank you, Senator Hoffman. A committee is only as good as its members, and all of you are handpicked. So yeah, I love this committee too and the work that we do. Commissioner Malcom, to his question.
Yes, thank you, Senator Hoffman. I so appreciate your always reminding us and getting us to focus on people with disabilities. We know that they too are at increasing risk and often are not called out clearly or specifically enough in these statistics. So we will absolutely take that back. Thank you, Senator.
Thank you. Senator Eakin has a question.
Thank you, Madam Chair. And Commissioner Malcolm, thanks for all the great work you're doing. I know how stressful this time is, especially for you, and dealing with the long-term care issue in particular. I was wondering about the issue of people coming into the nursing home from the outside, well, workers included. It seems to me that testing should really be focused on this area because this is where it's having the most devastating impact, is in long-term care. But making sure that our workers are tested on a regular basis. And what about family that do come in? I know that there's restrictions on that, but there are compassionate visits. And I've been told by one of the nursing home administrators that family members are allowed to come in to deal with electronic monitoring. I don't know if people in the nursing homes are taken out by family members on occasion. How is that issue being addressed as far as family members? And I know this is a very difficult issue because you know, the need for having connections with family is so important. But how do we do that in a way that protects the residents in these nursing homes, and what is being done in that regard?
Commissioner Malcolm.
Madam Chair, Senator Eakin, thank you. Those are great points. And Chris or Michelle, if either of you would like to address any of that, please feel free to chime in. I think you're right. I mean, we do believe, especially at this point in the outbreak, since the visitor restrictions have been in place and stay at home, and people in the facilities are not generally leaving the facilities, that new transmission is probably being brought in, you know, chiefly by workers, but potentially by family members, as you point out. So I think figuring out what is our best approach to health screening and potentially testing among workers and other visitors is going to be important. And especially because, as we've been saying, and the governor's been saying this pretty much since the beginning, and I think that is truly that sort of the national strategy, is that as we begin to open commerce and lift some of the restrictions on interactions in the general public, we're going to need to continue to be able to protect, to some degree, isolate people at higher risk, and to do that in a way that is as supportive as possible, as respectful of rights as possible, is clearly going to be critical. So if we're going to be in a situation, at least until there is good therapeutics and a vaccine, of having our vulnerable population remain more protected, if you will, figuring out how to, how best to know what's going on with the people that need to care for them and need to see them is going to be really important. I don't have a specific answer for you on, so what should that regimen be? As I mentioned, that study that we're doing with the CDC right now, we're hoping is going to really help us understand things like the frequency of testing that would be needed to get a really accurate picture. But I just want to validate that you're asking really good questions that will be with us for some time to come.
Senator Eakin, any follow-up?
Thank you, Commissioner. Thanks.
Commissioner Malcolm, I have one question. Back on April 8th, the governor said that he was 95% certain that by May that we would need 3,000 beds in our hospitals for COVID patients, and that ended up not happening. I'm wondering what is the new modeling saying? And now especially we know, in my opinion, all hands on deck need to be in our long-term care facility. If that's 90% of where the deaths are occurring, that's where I think 90% of the resources should be going. But what's the new modeling saying, or is there any lifting of this gloom and doom?
Madam Chair, thanks. The model that we've talked about a lot, as the governor has said, and I've said, and I know the researchers have been careful to say, is really it's a valuable tool, but it's only one tool in the toolbox, and is really more about directional changes than precise estimates. And I think, as the governor has described, the confidence intervals around the projections are quite wide. So I think that 3,000 bed by May projection was, there was a pretty wide range around that. That was, I think, version 1 of the model, where there is a version 3 that has been developed. That's being peer reviewed by some national researchers right now. So we have not rerun the model with the most recent improvements to it till it comes back from peer review. Probably we hope to be doing that in the next couple of weeks. But yeah, a lot of things have changed. We know more now about the role of asymptomatic transmission. That tends to push numbers up higher. On the other hand, length of stay and ICU use is lower than what was originally projected. So the variables are kind of, some are going in one direction, some are going in the other. So, but we expect to have another run of the updated model. I heard at one point that they thought that might even be by the middle of next week. So that was not something that the governor was looking for or waiting for the decisions that he just announced yesterday. But we will we'll have some updated out of that. We're also looking at lots of models, our own, but as you know, there are other models out there that have pretty different assumptions. The University of Washington model, the Institute for Health Metrics and Evaluation that a lot of people have talked about. Some of their projections are coming closer to ours, but in other respects, their model is still quite a bit more optimistic than ours. So we're looking to try to understand more about that. So I think we'll just continue to share with you the most recent projections that we have. But I think it's good news that we're getting both a clearer picture of what the actual capacity is in the hospitals. And Madam Chair, your point about we need to have as sharp a focus on long-term care as we do on acute care is exactly right. And we are taking some of the models that have been developed for acute care and now applying them to long-term care in terms of projecting, need and demand and PPE availability. So trying to use some of those tools and making them useful for long-term care as well. Is we couldn't agree more, and we're working hard to do that.
Thank you so much, Commissioner Malcolm. I just have to speak a little bit on behalf of all the people that called me yesterday and text and Facebook messages and crying. They're dying in a different way, whether it's mental health issues or suicide or complete devastation in their family because their businesses are going under. It breaks my heart to hear these stories and not focusing on where the devastation or where the casualties are happening in our long-term care facilities, and then blanketing the whole state when people are still walking in and out of Walmart and Target and they're fine and they're not dying. But our focus really needs to be, it's just a comment, and I know you know this too, but I have to speak on behalf of those folks too, because it's killing them. And I just feel that more of our focus needs to be where the people are dying. We've got 2 questions left, Senator Ralph and Senator Abler. Senator Ralph, go ahead.
Thank you, Madam Chair. Commissioner, again, thank you for all of your efforts. I know you're really between a rock and a hard place on a lot of this stuff. So I commend you on that. I just have a couple of specifics. I was looking at some of the statistics, and by the way, that the slide that breaks down it's called cases. I think that's a very good breakdown of information that I would like to see made available somewhere on the dashboard or somewhere in the figures that are being reported. I think the situation update, I follow it daily. I even have my own tracking that I've set up on it. But I think that's an important breakdown of information. So I want to just throw that piece out. The other question I have is, you had commented that there were cases where, and I think it was one of the slides where you talked about the use of testing aggressively in the long-term care facilities, and in some cases, it seemed like it was successful. In others, the cases continued to climb. And I wonder if you could comment just, I mean, I'm trying to follow up with some of the other comments about we need to really devote more resources to the long-term care facility. And I fully agree with those comments. But I'm just wondering if we're finding that the testing is taking place and yet it doesn't seem to be working. Is it because of the protocols that we have in place for a positive test, or do you have any handle on what's going on there?
Commissioner Malcolm.
Madam Chair, Senator Ralph, thanks. And Chris, if you're still on the line, I think you are. I think I see you. If you could please come on in and add some comments to that point about seeing the utility of testing, kind of the value of it, or the way that facilities have used it has been something I know that you have looked at.
Ms. Erzman? Maybe she walked away.
I still see her. Chris, you need to unmute, I think.
Madam Chair, Ms. Erzman is unmuted on my end as the Zoom host, so there may be an issue on her end with the audio, but the video is working.
Okay, Chris, we see you trying to talk, but you still seem to be muted.
Okay, maybe we'll just hold off on that and we'll go to Senator Abler's question, then we'll come back to Chris when she gets her. Senator Abler.
Thank you, Madam Chair. This has been a great discussion, and I think we've covered a lot of good ground. And kind of following up on
Chris, you're on
Senator,
now, so.
You want to go back to her, Mr.
Yeah, let's
Madam
go
Chair?
back to her. Sorry,
Sure.
sorry,
Okay.
Senator Abler. Okay, Chris.
Yes, thank you, Senator Hosley. Sorry, Senator Abler, and to Senator Ralph's question. Yes, testing is a useful tool because it gives you information about, you know, who among residents or staff may be infected or infectious. So that is really good. But unless infection control measures are put in place, unless residents are cohorted, as one of the senators asked about, if someone is, you know, is positive, then we would isolate them and a roommate would be moved someplace else. Unless you're doing really active and aggressive work to respond to the data in testing, it doesn't necessarily make a difference. And I want to acknowledge that the one facility, the healthcare facility that has the most cases right now, they tested everyone in the facility. And so we think testing is useful. We think it's an important tool, but just having test results without action to do the appropriate infection prevention measures will not make a difference. So that's kind of the important piece of it, is we really have to have the facilities working with us and implementing infection control and infection prevention actions in conjunction with the testing that they do.
Thank you, Madam Chair. Just a follow-up then. I've been kind of listening to the what's been done, and I'm troubled because it seems like the protocols that were in place once positive testing occurred were not clearly established, and it sounds like you're still evolving on this. And I'm just wondering if you can comment. It seems to me that as we ramp up testing, we need to not only have the protocols, but make sure that the facilities have them and are following them and have their staff trained. It just seems we're, what, 6 weeks into this, and I don't know exactly, maybe I'm not seeing something here, but it seems like we're still kind of a little bit in the dark as to what to do once we have this testing available. And I guess I'd just like some comment on that, because up to now, it seems like, okay, we've got a positive test, but there seems to be, the responses have been somewhat, shall I say, less than consistent, or at least it would appear that. And maybe I'm misreading this, but I wonder if you could comment on where you are with actual established protocols once a positive test arises, and how that's being transmitted to the various care facilities.
Yep.
Commissioner? Oh, Chris?
Senator Hosley and Senator Ralph, we actually do have protocols. We actually have provided those to facilities. And in fact, the calls that Commissioner Malcom mentioned earlier in her presentation, the weekly calls, we provide those with to the facilities. And then obviously the case manager and the team is working with them to say, these are the things you need to implement. But different facilities have differing levels of capacity to be able to implement the recommendations that we make. And as Senator Hosley alluded to, some facilities are really struggling with staffing. And so they're in different places in their ability to implement those recommendations. We do have them, we've given them to the facilities, we work with them as we identify cases, but there's a capacity difference. And so that does account for obviously sometimes differences in transmission within facilities.
Thank you, Chris. Did you have another follow-up, Jerry?
Well, I was just going to comment that seems to then call attention to the need for when there is a facility that apparently is not following up. And I think this goes back to a lot of the things that we've been talking about, as Senator Koren referred to, for several years, that at that point in time, we need to focus on that facility. And I know your staff are stretched, but it seems to me if we've got a facility that's identified as at risk because of an infection, and first of all, we know from the past that maybe they haven't done the best. And secondly, their response is one of, well, we need staff that's something. I'm just wondering if there's something in place to try and focus on those facilities. Otherwise, we're going to continue to have these large outbreaks in some of these facilities. And then that concerns me, because then those staff are spreading it throughout the community. So that's just kind of a comment. And if you have a further thought on it, that's fine.
Madam Chair, Chair, this is Jan. I just wanted to chime in on that point and say, Senator Ralph, I think you're right, Madam Chair. You've said much the same. Many members have, and that's why we are trying very hard to kind of assess. Okay, as you said, 6 weeks. That we didn't know before, and some that we didn't have before. So what's the next phase of our response? And both on the emergency side, how do we get faster and better when we see a problem coming? And then more holistically, given that we know this is going to be with us for a while, what is our longer term plan that isn't just about crisis response, but it's about building more resilience for the longer haul here? And we are working to build out more elements of that plan. Some of it really is a challenge, that you know as well or better than anybody else, is the as an industry. But we're also talking a lot and working very closely with industry leaders on this reality that this is going to be an ongoing challenge, and we can't just go from crisis to crisis. To you and hearing from you that are really more systemic solutions for the long haul.
Thank you. I think you stopped talking there, Commissioner. I think.
Still having some computer on and off problems. I hope you can hear me okay.
Yes, and I know you have to scoot out, but your staff will stay here for some more remaining questions. But I just want to say to you, Commissioner Malcom, that this is my 8th year in the state Senate, and I've never worked with a commissioner that has been as respectful of differing opinions and as engaged with us as you are, or nor has anyone been more committed to the people of Minnesota. So I seriously I want to say thank you. I can't imagine, it's not easy being in a position where everyone is critiquing what you do, and you really handle it with class and grace, and a genuine desire to work with us to better the lives of people of Minnesota that we represent. So I think we need to keep in mind that going forward, we all want to see this work. I want to offer my personal commitment to you, Commissioner Malcom. Anything you need from the legislature, we've got a kick butt committee here that would love to work with you to help the people of Minnesota. So thank you for staying with us for this hour and a half, and everyone else stay on for a few more minutes because we do have some more questions. So thank you, Commissioner Malcom. And we can't hear you.
For all you are doing as well. You have been so responsive when we've asked for help, and there will be more. So thank you so much. Signing off for now. Thank you.
Thanks, Commissioner. All right, Senator Abler, sorry to cut you off like that, but I knew she had to go.
It's all right.
So Senator,
no,
okay.
That's fine. And, you know, Senator Hosley and the rest, I look forward to actually having meetings in person. I mean, we can look at all the little people on the little view boxes like Hollywood Squares kind of, but it's not the same as talking in person and seeing all the side glances and the body language. So anyway, just to follow up on actually what a couple people have mentioned about the uniform standards. So it sounds like there's a list of things that the department has thought of that are the best practices, but there's some implementation issues. And Senator Hosley just mentioned to you, we were both concerned about posting places that had infections, but I think we should be more concerned about places that are unable to staff and that don't have the best practices in place as a way to somehow move them along toward what's best. And I think if there's a PPE issue, the governor has a very strong hand these days. And I think that we want to make sure that in these areas that's available. This is where the people are dying. They're not dying at Target or in the closed shoe stores on Main Street. And so, Ms. Erzman, just a question on the thing, and then I have one more question, Madam Chair. On these visits for people when someone's dying, is there a uniform standard about that the people get to go say goodbye to their loved ones? Somehow, it seems like there's kind of a patchwork about that. Do you know, Ms. Erzman?
Ms. Erzman?
Senator Hosley and Senator Abler, our recommendation is that there is allowance for compassionate care situations. Can you hear me?
Okay. Yep, we can hear you.
Okay, I'm a little paranoid. No, so the recommendation from the Department of Health is that there is allowance for compassionate care situations, so that families should be allowed to visit their family member at that time. We have heard that there have been some facilities, and I think out of extreme fear over the situation, that have limited that, but that is not our intent. And when we're made aware of it, we reach out to the facility and let them know that they should be allowing for that. I have friends whose mother has COVID now in a facility, and they put her in hospice, and they have been allowed to spend time with her. The facility graciously has provided the personal protective equipment and everything that they need to be able to be with their mother. And that's how we would like things to be for everyone. And so if we are made aware of a situation like that, we will reach out to the facility to address it.
Thank you, Madam Chair, and I'm glad to hear that. I just have one more question, kind of following up on your actually most eloquent comments about mental health and so on. And, you know, I share those same concerns. Ms. Erzman, are you tracking upticks in, I don't know if you track child abuse, that's probably a county thing, but do you keep track of suicides and the increased police activity about some of those things that I've been told about in some way that at your department?
Ms. Erzman?
Senator Hosley and Senator Abler, the department does have in a different division, we do look at information related to injury and violence prevention, and that would include suicides. Because those are not infectious disease related necessarily, I don't have that information, but certainly if you're interested in that, we can get that for you.
And Madam Chair, and I'll stop pretty quick. That would be very useful, and I'm curious just how up to date that is. And so, Ms. Erzman and Commissioner Malcom, who's gone, I know that for you, an injury is an injury and a death is a death, and they all matter so much. And so, I just will re-comment from Senator Hosley's comments that some of these related matters that are secondary to the, how we're approaching the COVID thing are going to last a long time too, and the impact on a family with somebody who takes their life or is abusive and so on is just really a big deal too. So, and I want to thank you for your work. And I hope I've been straightforward today, but I have great appreciation for the efforts you're putting forth, and I want to wish you the best and all that. So thank you, Madam Chair.
Thank you, Senator Abler. I think that's the end of our questions. So I want to thank you, Ms. Erzman and Ms. Dotseth, for being on this call too. And again, thanks to the Commissioner. And I want to thank all of our members of the Long-Term Care and Aging and Family Care Committee, because I love this work, and I know you guys do too. So thanks again. Have a great weekend, and that concludes the Long-Term Care and Aging Committee. So we're adjourned. Bye, guys.
Thanks, everybody.
Thanks.